Very good morning to all of you. With due respects to my teachers in ophthalmology, thanks to AIOS, regards to Uttarakhand Ophthalmic Society for allowing me to present my credentials for this prestigious award. Luckily, 3 years short to the age bar, and this year got invited as an international guest speaker, and our innovative SFL technique got acknowledged by American Academy of Ophthalmology. At the international level, credential in the last included, we conducted an instruction course in American Society of Ophthalmology. Thereafter, presented my work on toric IOL fixation in the subluxated cases in Amsterdam Uretina. And in the Bhutan, we presented our surgical management of subretinal bleeds this year. Credential of the last year at the national level included the first prize in the Chandigarh Eye Film Fest, Eminent Faculty Award from MP State Ophthalmic Society, Himachal Pradesh Ophthalmic Society, conducted a invited faculty lecture in North Zone, COS, VRSI, and the RFR organized by PJ for the consecutive 2 years. Coming to the innovation part, this is the
Sutureless scleral fixation with advantage of not requiring any forceps, any glue, no haptic exposure, no hydrophilic oil, obviously no suture, and can be performed through 3.2 millimeter clear corneal incision 2. Center of the cornea and adjacent limbus marked accordingly. Localized peritomy performed. Infusion source applied. One can use the AC maintainer too. Scleral pockets fashioned parallel to limbus with right-handed directed inferiorly and left-handed superiorly to match haptics direction. 1.5 millimeter marks applied at the entry of pockets. 26 G needle with silicone band segment prepared. 3.2 millimeter corneal entry made. Holder folder forceps. Injector or simple curved forceps to fold and deliver the IOL. Needle brought out taking care not to pierce any corneal tissue. Haptic threaded over 26G needle followed by IOL delivery. Haptic brought out and retained with the aid of silicone band segment, obviating the need of any assistant. Similar procedure performed on the other side. For haptic insertion, just hold anterior sleeve of the pocket and slide therein only to save off any haptic exposure. Port is hydrated and cautery applied to oppose conjunctiva. Compared to Yamani's, this technique has no trailing haptic issues. A hydrophobic lens is used. No glue or trained assistant for IL injection is required. No haptic exposure or special forceps as Gerber-Sherratt forceps for haptic insertion is required. Thank you so much.
Luckily, this technique turned out being the most commented technique for the consecutive last 7 months. And we got an invite for the write-up by the PJ in the COS newsletter this year too. The other parts of the SFL we are working on is the SFL tilts. You can see up to 90 degrees of the tilts can be corrected with the tram track suture, and the toric oils can be refixated, like in this case, back to the 62 degree. Other parts, we are working the POBH use in traumatic cases, like in the open globe injury cases, closed globe injury cases, the membranectomy cases, as the dialysis with the PC rent, because rather than going for the SFL, it can be used as a sturdy support in such cases too. The other parts are the aspects are the RP choroidal graft and the retina grafts and the subretinal bleed managements. These grafts should rarely be done in such cases with a massive subretinal bleed in the one-night patients, and they are not able to have the contraindication of the VEGF or the refractive conditions. So what we do after the base dissection vitrectomy, induce the localized detachments, use the fluid exchange to push the fluid behind, then do more than 180-degree RR, and thereafter take all this CNVM complex and bleeds and the cauterize those feeder vessels, as well as thereafter, under the PFCL, mark the area of you can see the normal area of the RP choroid. From there, we take the graft. You can see the underneath sclera. I just take it with the help of the curved scissor. Then the PFCL is taken from the underneath and put on the retina, followed by the retina laser and the PFCL oil exchange. The graft, nicely in place, can be seen in the post-op period. We are the first one to do the autologous retina transplants in the country, I will say, since 2018. I got the first best case series prize in 2019. The graft is nicely in place, bridging tissues formed, and at times you can see the underneath photoreceptor layers regeneration too. Subretinal bleeds, whether you manage with the help of BSS, TPA air, or within the diabetic cases from the breaks, you can take the help of the extrusion with the help of cutter, or the external drainage in the cases, or in the traumatic one-head cases where you can use it with the help of a cutter and like a spaghetti drainage. The aim is to create a vision in such eyes. Thank you so much for your patient hearing.
You are telling no forceps. So, what precaution to be taken before that? To good vitrectomy, other than good vitrectomy, what precaution we should take to avoid any complication?
You know, we have been doing this technique for almost now 4 years, and almost more than 200 cases we have done. The problems with the X-nick technique was that there was a part of the haptic which remained exposed, and it states the chance of getting the endophthalmitis in the cases. Rather than getting any of the vitreous, as you rightly said, the cases, the hurdle which was faced with most of the surgeons and their segment surgeons, that they were not trained in the SICS. We been trained in SICS, but many new generation surgeons are not trained in SICS. So there was a hurdle for them to make the SICS tunnel. So by using the 3.2 millimeter clear corneal tunnel, it can be done. And other things which should be taken care is while handling the trailing haptic. And you should exchange your right hand to the left hand so that you can use your right hand to insert the trailing haptic in. And this we have been doing for the last 4 years right now.
Retinochoroidal transplant, how many cases you have done and what is the visual acuity in that cases?
For the autologous retina transplant, I would like to say that we have done almost 12 cases till now. And there are two aspects of this, the clinical aspects and what the study says and what we felt in the real world scenario. The one thing we felt that no doubt the scotoma size decreases. Even in the microperimetry, we have picked that the spots can be, the patient started picking. Even in so far the vascular part is concerned, the development of the CNVM itself in such cases, means that there is a vascular connection which has developed. If we see and we have seen the patient gaining vision up to 660, but not more than that, I will accept that. And almost 40% of the patients had the visual improvement, 30% patient did not had. Two of the patients had the detachment also in the initial cases where we were not using the cutter to induce the localized detachments in such cases. Other than this, from the studies, if we say that they have been the pluripotency of these stem cells in the peripheral retina has been reported as such, and the immunohistocompatibility of the retina to the central retina has also been reported. But these are all the theoretical parts of this.
Thank you so much.